Okay, we will be live in about 3 seconds. Hello, and welcome to the second panel in our 3-part Anesthesiology Residency Application Virtual Forum. My name is Caitlin Gaudio. I am a 4th-year medical student, a member of the Anesthesia Interest Group Executive Board, and the New York Medical College delegate to the American Society of Anesthesiologists Medical Student Component. I'm joined by my colleague, Kerrigan Perry, a 4th-year medical student at New York Medical College, and we are so very excited to be hosting this evening's event. I would first like to introduce our guests. We have Dr. Sarah Smith, the Residency Program Director at Westchester Medical Center, Dr. Joy Schabel, the Residency Program Director at the Renaissance School of Medicine at Stony Brook University, Dr. Vlad Frenk, the Residency Program Director at the Frank H. Netter School of Medicine at Quinnipiac University, and Dr. Judith Aronsohn, Residency Program Director at the Donald and Barbara Zucker School of Medicine at Hofstra, Northwell, North Shore University, and Long Island Jewish Medical Center. I would like to thank everyone for joining us tonight. I would also like to thank our faculty advisor, Dr. Garrett Weber, for all of his support, and Dr. Apollonia Abramowitz, the Associate Program Director at Westchester Medical Center, for all of her hard work behind the scenes to help make these events possible. We invite all of the participants viewing on YouTube to submit questions to our Slido, which should be linked in the video. Please note we might not be able to get to all of the questions, but we will do our best. To start off, I'd like to give each program director 2 to 3 minutes to introduce themselves, introduce the resident physician joining them tonight, and give a brief overview of the program. So we'll start with Dr. Smith.
Hi, good evening, everybody. I'm Dr. Sarah Smith, and I'm an associate professor at New York Medical College. And as of today, I've been residency program director at WMC for 29 days. I swapped places with Liz Abramowitz, who had been the program director here for about 8 years. She's staying on as vice chair of education, thank goodness, because otherwise I don't think I'd be able to do my job. And she is associate program director. Westchester Medical Center, we're located in Valhalla, New York. So if you're wondering where that is, it's just a little bit north of New York City, close to White Plains. We're a level 1 trauma center. We do a little bit of everything. It's a very busy place. We get a lot of referrals of very complex patients from very far upstate. We have the only burn center north of New York City, among other things. We also have a dedicated children's hospital. We have a very busy cardiac service, which I can speak to because I'm one of the cardiac anesthesiologists. My buddy who's on call tonight, I just got a text, he's getting ready to start another type A dissection. We do a lot of those. That's about it. I'm excited to, answer any of your questions. I'm really looking forward to this first interview season.
Thank you so much, Dr. Smith. I'd next like to invite Dr. Schabel to tell us about her program.
Sure. Welcome, everybody. I'm Dr. Schabel. I'm the program director at Stony Brook. I've been the program director here for about 7 years now, approximately, and I was associate program director prior to that. My resident with me tonight is Dr. Dan Matamore. He's one of my CA3s. He was a graduate of the Tufts School of Medicine in Boston, and he will be heading to Duke University for a cardiac fellowship starting next summer. So for a brief overview of our program, we are a medium-sized program. We take 12 residents per year. We're located in Stony Brook, New York, which is on Long Island, pretty much midway between the Hamptons and Manhattan. So depending on what your flavor is, you can go either way for some extracurricular enjoyment on your own time. More about the program, we are level 1 trauma center, and we do a lot of different types of trauma. We have high-speed motor vehicle accident type of trauma. In the summer, we have boat trauma, jet ski trauma, and some of that trauma is actually pretty extensive due to the nature of being an island, and all of those sorts of cases come to us. We are a level 3 neonatal intensive care unit. So the little teeny babies, any mom pregnant who's going to be delivering preterm in this whole catchment area, which is really pretty wide for our hospital, will come here and deliver at Stony Brook. Our catchment area reaches all the way out to Montauk and goes to about like Melville or so on the island. If you don't know where those places are, it is about 90 miles in diameter. So lots of variety of cases, a lot of complex cases. We're pretty much the only show in town in terms of university academic centers. There's not another center like 5 blocks away or 4 miles here and there. You can actually see us on the ferry. We kind of like stick up because we're the only like tall building for like a very long particular area on the island. And I think that's pretty much it. Did I miss anything, Dan? Anything else about our program? That's a nice overview.
That's a very good overview. Yeah, you're well experienced on this.
Okay.
Thank you so much. I didn't realize there were so many boating accidents for people to possibly get into, but when you're Long Island, I'm sure you're quite used to it. Next,
Especially with the alcohol too. Some people, alcohol and boating is similar to alcohol and driving, believe it or not. Leads to a lot of accidents.
wow, yeah. I can imagine those cases are quite intense. I'd like to invite Dr. Frenk to talk about his program next.
Sorry, good afternoon. I'm Dr. Vlad Frenk. I am a program director at Quinnipiac University in Connecticut. So Connecticut is a smaller state than New York, and it has 3 medical schools, and now it has 3 anesthesiology residency program. We are a newer program. I've been a program director since the inception. We just matriculated our first class, and Dr. Maham Ahmed, she's here. She's one of our CA1 residents who recently started with us. She's a graduate of SUNY Upstate, and she did her surgical year before she joined us at Quinnipiac. We are a level 2 trauma center, and as opposed to other places, we do not have children's hospital, no NICU, no pediatrics whatsoever. However, we have a close affiliation with Connecticut Children's Medical Center, and all our residents are rotating for 3 months at Connecticut Children's to fulfill their pediatric requirements and get exposure to complex, unusual, one-of-a-kind, and simply impossible procedures. The rest of the time they spent with us at St. Vincent's Medical Center. It's located in Bridgeport, Connecticut. It's along the shoreline of Long Island, but on the other side from Stony Brook. Not many boating accidents, more motor vehicle accidents, and other drug-related accidents. We do pretty, like, our specialization and what we're known for is early recovery after surgery, narcotic sparing surgery, and this type of surgeries that we have a diverse and difficult populations who come in for your more bread and butter type of procedures. And our program is focused on training residents who are going to be well versed in these narcotic opioid sparing pathways. And that's pretty much all I have.
Thank you. I know we're all really excited to have another program in Connecticut in the greater New York area. And we're really excited that you're here to teach us all a little bit more about your program and what you guys have to offer all of us. And last but not least, we'll have Dr. Aronsohn tell us about her wonderful program.
Well, thank you for, first of all, for having me and my wonderful CA2 resident who's here tonight, Jasmine Tuteja, who's just an outstanding addition to our program. We are a kind of like a threefer here because we have three hospitals in very close proximity geographically to one another where our residents train. They're both, they're all tertiary care centers. We have the Children's Cone's Children's Medical Center, which is our dedicated pediatric level 1 trauma. We do, I don't want to be repetitive to what everybody else has said that they've done. We do pretty much all of those things, but I don't know whether anybody mentioned solid organ transplant. We have a very, very busy transplant service, which is growing every year. We do liver, we do cardiac, heart and lung, pancreatic transplants. So this is a very exciting new growth and development in our department and in our program. We're relatively new. We're a little bit older than Dr. Frenk's program, but we're definitely newer than the Stony Brook and other New York programs. So we've graduated about 8 classes. I only mention that because we're in a constant evolution and growth and development mode here because of that. I actually was recruited to start this program in 2012. So it's not an old program, but it's not a brand new program either. We're not the newest ones on the block, but we are growing. And 2 of the most exciting things we have now that are very recent in our development is we have a new academic chair, Dr. Stephanie Jones, who just joined us last March. And we also have approval to double the size of our program. So we are a small program now, graduated to be an intermediate sized program. We're going to be putting 6 R spots in the match this year and 6 additional to the 6 we already have, PGY1 spots. And this is only one of, I think, hopefully many growth spurts that we'll be having in at our North Shore LIJ and Cone's Children's locations.
Okay, thank you to everybody, all the program directors, for giving us all a little snapshot of your programs, your individual programs. As Caitlin said earlier, my name's Kerrigan. I'm one of her classmates. I'm going to get us kicked off with the first question. This question is geared towards both the program directors and residents. So if anybody wants to jump in after I read it, please feel free. Our first question is, what are 3 words that you would use to describe your program? Since no one's jumping in, and Dr. Smith, you're the first on my my little Zoom window, so we'll start with you.
Sure. So, and leave it to the newbie to forget to introduce her resident. I'm joined here today by Raul Kataria, who's one of our CA1 residents. Just started in the, well, not just started in the OR with us because our residents do rotate with us as PGY1s, and he's from the University of Illinois. So I guess the 3 words, I think I would say exciting. It's an exciting place to work. I'd also say non-hierarchical. I think that we're actually a pretty approachable group, that, you'll see the chairman of the department, Dr. Panzica, working in the ORs. He's somebody who, the residents can actually knock on his door. Just a little while ago, he gave a lecture to them about, looking for your first job and negotiating contract terms, things like that. So that's 2. And then let's see what else. I think I would say, fun and collegial. Yes, that's 2 words. But I think we do have a good time, with the working here and in this kind of fast-paced environment. But we make it fun. We make it kind of like a team sport. It was actually a really good place to work.
Thank you so much for sharing those things. I guess we'll move on to Dr. Kataria. Do you have anything to add to that?
No, I mean, I pretty much agree with all of that. We see a very diverse array of cases here, from super sick, and despite how challenging it can be sometimes, the attendings make it are very approachable, where you can ask, no question is a stupid question. And it makes it easy, especially when you're first starting out. Taking everything in can be very overwhelming, but having the support of, the attendings and then also senior residents makes that transition a little bit easier.
Yeah, thank you for adding that in. Going forward, if the residents just want to if they have anything to add to what the program directors say, feel free to just jump right in. And if not, we'll continue on to the next program director. So the next one in my window is Dr. Frenk.
3 words. Okay. The first one is intimate. We are a small program. We only match 4 residents, and our faculty and staff were very close. So we pay a lot of attention to them, and they are always on our mind and on our radar, for better or for worse. Second word is going to be young. And I don't mean about the age of our program, but I mean the age of our faculty. I would say about 70% of our faculty graduated within the last 4 to 5 years. And so therefore they are close to resident year themselves. They're enthusiastic about teaching. They are driven. And you don't, like, when I ask for volunteers to get involved in some teaching and educational activities, usually I have to turn people away as opposed to beg them to join. And the third word, I kind of already alluded to it, is narcotic sparing. We are big into regional anesthesia, narcotic sparing, minimally invasive, and so on and so forth. And Maham?
Yeah, I extensively agree with that. The regional part is a huge, regional anesthesia is a huge highlight of our program indeed. I did my residency in surgery before making the great switch to anesthesia at North Shore LIJ, and saw obviously very different practices. And what I really enjoyed was the difference I saw in postoperative pain control and analgesia. So the regional techniques that we use are absolutely phenomenal. You become a very seasoned anesthesiologist, especially trained in regional anesthesia, along with all other aspects. And the intimate nature of the program is pretty amazing. I think, as a lot of people here, anesthesia can be a bit of an isolating field. That's what I heard during interview trail, and that's something you guys might hear as well. And coming from surgery, which is much more cohesive, that was a bit of a concern on my mind, but I haven't experienced that one bit here. And I think the reason for that is because we are a smaller program. Everybody's very involved and very, Dr. Frenk is so focused on our education. And another word would be a mini Yale residency, because most our attendings are Yale graduates, so they just pull into our private group of anesthesiologists. So we get like a mini Yale residency, because they've all learned from there, and then we get all these pearls from them as well.
Thank you to you both for sharing your thoughts and answering. I think the narcotic sparing, the regional anesthesia aspect is really interesting, and I think that's maybe not something that somebody would know without hearing it from somebody in the program, and I appreciated that. So we'll now move on to Dr. Aronsohn.
Sorry, I was muted. 3 words. So the first I would say is supportive, because I think, we pay particular attention to that based on the fact that the residency program is so small and the department is so big, that we go to great lengths to ensure that all of our residents feel that they are working within a cohesive group of, a special group of teaching faculty. There's no getting lost in this program. They feel that every step of the way, not only do we support them, but they never feel that they're put in situations that are above their head or that they're, not equipped to handle. It's just like part of our teaching philosophy. But on the other hand, we want to keep them challenged. So their education is very personalized as they go through the program. This helps us, as they grow and they develop, keep them in cases that they feel are, you know, they're the next level, the next place that they want to hit, the next level of complexity. And they're not sitting in, you know, bread and butter cases. If you're a CA1 and you're excelling, we know that we have a perfect picture of where you are in training, and we advance you accordingly. We don't advance you according to your, you know, necessarily how many months you've been in the program or how many years you've been in the program, but truly we want to advance you based on your aptitude and how fast you develop and help you in areas that maybe you're not developing as fast or as rapidly. And we're a very diverse program, and I don't just mean that our residency is diverse or that our residents are diverse. Our faculty are diverse. We, as opposed to maybe, you know, a program that has a lot of faculty that are all from, you know, trained at the same place or worked at the same place before coming here or did fellowship in the same place. The department is so large, we pull faculty from all over the country. And that offers our residents a very diverse view of how attendings handle cases. So it's not, there's no inbreeding here. There's no North Shore LIJ way of doing things. Everybody brings a unique way of handling cases to the program and to the department. And Queens is very diverse. So we have these 3 hospitals here. One's in Queens, one's on Long Island, and, you know, Cohen's Children's is attached to LIJ. There's no more diverse patient population in the country than there is right here in Queens. So we consider ourselves to be a very diverse program with a very diverse patient population with 3 places that have very different cultures. And I think that that adds dimension to this training program that is not available everywhere else. So again, it's supportive, it's challenging, diverse are the 3 things that I would come to my mind. And Jasmine can add something if she wants, but I don't want to like put her on the
Yeah,
spot.
of course. So I definitely agree with all of that. I think, you know, attendings, because they work so closely with us, they know our level, they know exactly where we're at, and we're constantly put in situations that force us to grow, while also they are supportive. They're right around the corner if you need them. But I really appreciate the kind of autonomy that they give us. And like Dr. Aronsohn said, once you're comfortable in a certain type of case, then you're given a slightly more challenging case. And I think that us being such a cohesive program really helps with that.
Thank you so much to you both. Yeah, I think the personalized approach sounds really interesting and really beneficial. I thank you for sharing that. Last but not least, we'll move on to Dr. Schabel.
Sure thing. So I would say the first adjective would be comprehensive. I think our program offers a very comprehensive level of training. Our residents, I believe, when they graduate, they can anesthetize any patient in any situation at any time, and do a great job with that, just because of the complexity and diverse type of cases that we see here. A couple of years ago, I had a private practice chief reach out to me, looking for grads, you know, to hire, and he told me that you guys have a nice product. You know, I corrected him saying these are people, these are residents, not really like products. But in his mind, he just was very happy with the residents that would leave us here and join them there, because from day one, they could just really manage anything from high risk OB to a very large patient with a difficult airway to regional blocks. So I think that was a very, good testament of our graduate, I guess you can say product, but really the skill level of the training that they receive here. So that's number 1. Number 2, I would say tight knit. Our classes, for whatever reason, year after year, they tend to be like little families, little brothers and sisters. They make fun of each other. They have nicknames for each other. Sometimes I don't like the nicknames that they call one another, but I really try to stay out of it because it's all like brothers and sisters types of things. Our recent graduating class was exceptionally tight knit, that in June, 9 out of 10 of them all went on a cruise. And we had to really struggle to try to get all that class out on vacation because, you know, from a program level, that's a difficult thing to do. They go to each other's weddings. If someone's sick, they support one another. One of the CA3s last year had an unfortunate sudden loss of her dad. And it was just so warm to see the rest of the class almost become like an amoeba around her, just to support her to get her through the rest of the year. So tight knit for sure. But also tight knit with the faculty. We're pretty casual here. a lot of times first name basis of things. So I think it's like a family on many different levels here, certainly within the resident classes, but also with the attendings and the program leadership. And lastly, I would say balanced. I think we're a balanced program. Certainly our CBY year, that internship year, has a variety of different rotations in it to give balance to the traditional intern, like medicine or surgery that people, may have the, experience of having in a classical PGY 1 year. Even our CA1, CA2, CA3 year, I think it's pretty balanced in terms of certainly learning a lot of high complex types of anesthesia, but also getting out on time. We have these protected academic days where they have non-clinical time, just completely dedicated to learning. They're not put on the OR schedule. And I think that also offers a balance to their life where it's a time where they don't have to rush around in the OR. They can just wear their jeans all day or college sweatshirts, and they eat together. And I think it offers a lot of peer support for them.
Yes, I mean, I agree with all that. The classes that graduated before me, those two classes, like I remember all of them across the board were just excellent anesthesiologists, and hearing stories of how well they're doing now, some on Long Island, some in other states. They can handle almost any situation. And I think as a junior resident at the time, you kind of wanted to be like them, and they would teach you on call and everything. So, it's between classes as well, there's a great supportive environment. There's the program gives money for wellness events, whether that's a Halloween party. We're going to do something in September for, maybe apple picking or something. So golfing. So there's always events going on. We always support each other. And I think those dedicated academic Wednesdays, what we call them, every 3 weeks, we get the whole day off, dedicated to lectures and learning and sim sessions. That's a great way for residents, like every 3 weeks in your class, you're all together. You have lunch together, you're catching up, talking about stories in the OR, and it's just a really great environment. And past 3 years with anesthesia have been great.
Thank you, everyone, for all of your insights and helping us really get a feel for the sense of community and culture at your program, something that's hard to really grasp on paper. So thank you for bringing your programs to life and sharing these things with us. My next question is also going to be directed towards both the program directors and the residents. And this is, how does your program help residents transition from their intern year into the OR for their CA1 year in terms of one-on-one mentoring, boot camps, and other structural kind of transitions? And for the residents, what did you think that experience was like? We'll start with Dr. Aronsohn.
We actually start this in the PGY 1 year, because when the PGY 1s start, they get a buddy that is a CA1 who just finished their PGY 1 year. So when the PGY 1s transition to the CA1 year, and we do this in June, we have all of our PGY 1s actually do their anesthesia elective in June. So they come in a month early, and that's when our boot camp starts. They have a buddy already that they already know from the PGY 1 year who's just a year ahead of them, that is available to them all the time. And they go out to dinner together. I mean, they actually really make very good use of one another. That helps with that transition into the CA1 year. Someone who just went through it, that can answer any of the questions that they may feel uncomfortable asking an attending or even a senior resident. When we make this transition in June into the actual CA1 year, of course, we have lecture every day in the afternoons, and we have sim once a week in the morning. Again, not unlike probably many other boot camps that happen. And this goes on for all of June and all of July. In addition, because we have both North Shore and LIJ as major training sites, and no one in the CA1 year is starting out in peds, we start half of that class at North Shore, and we start half of the class at LIJ. Each new resident is assigned a CA3 resident to work with in the operating room. That is a constant, right? That person does not change for 3 weeks. The attendings are pretty constant, but the resident, you one-on-one, that consistency is easier for me to get than attending consistency. They get both, but that resident stays with them. That senior resident stays with them for 3 weeks so that there's no confusion about how different people learn how to set up a room. There's no confusion about how different people do their pre-ops or how different people, do anything, all right? This is how you set up. You stay at that one site with that one resident for 2 months. And after you have gotten acclimated to that one site, either North Shore or LIJ, and after 3 weeks, you will now graduate to a wider pool of residents and attendings. But after 2 months, you will switch to the other site as a group and repeat that process for another 2 months, so that you get a really good, solid foundation minus all of the confusion. You get the consistency that you need really to, build your training wheels and take them off, after those first 3 or 4 months. You are ready now to advance, to all the subspecialties that we offer, those rotations in the CA1 year. But the feedback that we've gotten about that, the buddy system and the consistency of working with the same people at the same site for at least the first 3 weeks, and then the site the first 2 months, has been excellent from well, I'll let Jasmine comment on it because she went through it, and she's one of our excellent buddies and mentors for our, PGY1 and CA1 years, but that's how we do it here.
Yeah, so like Dr. Aronsohn said, when I was a CA1 going through it, I appreciated the consistency. We worked with mainly one senior for a couple of weeks and then worked with a different senior for a couple of weeks. And I think that, working with someone for just one day or one case is just a quick snapshot. But when you work with someone for so long, they really get to know, areas that you're really good at, areas that you can maybe improve on. And it also just really helps you grow closer to the senior residents. So I really appreciated our boot camp. I never felt overwhelmed or alone or anything. There was always support. And Dr. Aronsohn herself is such an incredible support system when we're all going through that as well.
Well, thank you both. That's really wonderful. I mean, having a peer that can act as a mentor and a role model, I really think that would make me feel comfortable, as well as I'm sure a lot of my classmates, when you're in such a new situation that's known to be a bit of a steep learning curve. So that sounds like a really great way of doing things. Next, I'm going to pass it off to Dr. Frenk.
Well, it's hard for me to compete with Dr. Aronsohn because she's been doing this for a long time, and I just started a couple of months ago. But since we're all friends, I ripped a lot of ideas from Judy, some ideas from Liz, some ideas from other people. So I learned from the best. What can I say? Our program starts at the PGY2 level, so some people are not anticipated that they will all do their internship at our institution. As a matter of fact, the current CA1 class, they all did their internships elsewhere, and our current PGY1s, 2 of them are in our institution, 2 of them are not. So therefore, we cannot really start earlier. So our boot camp starts in July, and the way that it's, I'll let Maham actually tell you the real story, but the way it was planned is that we don't have senior residents. So at first they're assigned a junior faculty mentor / buddy. I know it's not the same as having a resident, but at least that's some resource that they can and may use if they choose to, for lack of senior residents. And we selected these people based on their proximity to graduation from residency or fellowship themselves. Then for the first month, the way we do it, we pair a resident with an attending for 1 week at a time. So you do have different attendings, but for a longer period of time. And we don't start clinical rotation until like second week into it. The first week is orientation, machine checks, and making sure that everybody's ready to go to the operating room, so we don't have to go through machine setup and things like that before. it gets started. Then during the second months, we keep the same attendings, but the frequency of exposure increases. So you work with the same attending 1 day at a time or 2 days at a time, as opposed to a week at a time. But it's the same people that you see, the same faces over and over again. We try to keep cases consistent as well. And of course, there's a lecture in the afternoon every day. And at the completion of boot camp, we are undergoing a graduation simulation that I'm pleased to say all our residents passed with flying colors today. And as of tomorrow, they're going to 1 to 2. Yay. Okay, that's all I got.
Yeah, from speaking from personal experience, I think with anesthesia it's very different, right? Because we are so one-on-one with the patient. So the perspective of how much autonomy you want and is necessary for your learning process is very different from other subspecialties. And I'm saying that because a lot of, obviously, as we're going in, as you guys are going in as interviewing applicants, that's something to consider. So initially we started off with a lot of one-on-one time with our attendings. Attendings were great. They were all very close to residency, so very easy to speak to. It was as though you are essentially with a buddy. A lot of them do want you to speak to them, in a very formal manner, and are very approachable. We learned their ways because, again, everybody's way of setup is different. Their preferences of different drugs for induction and pain control, et cetera, is very different. So it does help having some continuity. So 1 week per attending. And then they started giving us a graduated autonomy. And I think that 1 month mark was just the right mark. Initially, we were all, getting scared of that 1 month mark not being sufficient. But after that 1 month mark, having a little bit of that autonomy going in is very, very important for your growth, to be left alone at times, but they would just be literally sitting outside the room on the stretchers or whatever with their laptops and pretending like they're not watching, and then slowly to going to the bathroom on their own, and then entirely just starting off the cases with us, and then giving us morning break and checking in via text. So having that autonomy at those right spots is very, very essential as a part of your training as well. And I think it was timed very perfectly by the program. So we all hence felt pretty comfortable, all 4 of us today on simulation day, to, go through those multiple things that can go wrong with that poor mannequin. Went through 8 different types of issues, which I'm sure won't ever happen.
Don't exaggerate, only 6.
Okay. So yeah, I think that our program really pads us up well for that transition, and we all feel extremely comfortable having 4 days initially of general anesthesia, and then mixing that up. At least every Friday is our elective Friday. So we are in cardiac rooms or neuro rooms, ortho rooms, to kind of mix it up a little bit. But it was kind of my idea that we should stick to the general stuff in the very beginning, at the very least, to kind of set the foundation, so the foundation's not too shaky, because cardiac and et cetera gets a little obviously complicated. So if our foundation is good, we should be okay to take on that extra pieces. So yeah, that's the gist of it.
Thank you. I think that it's really good advice for especially us prospective applicants. We grow when we're outside of our comfort zone, and it's good to know that you felt like you were really ready for the challenge. And then, the timing worked out well, that you had the confidence, but also you were excited to be pushed a little bit. Next, I'm going to pass it over to Dr. Schabel.
Okay. So we are a 4-year program. Our PGY 1 year is included. And what we do at the end or near the end of the PGY 1 year, we schedule all of our anesthesia interns to come and do the same rotation at the same time, which is called Introduction to Anesthesia, also known as boot camp, but the proper term is Introduction to Anesthesia. And during that time, they have lecture every day, usually 2 hours a day of lecture. During lunch, we provide lunch for them. So most of them tend to gain about 2 to 3 pounds during the course of the 4 weeks. They have sim. They probably have sim one to 2 times a week, I would say. We have a sim center right on site. It's probably, I don't know, 200 feet from where I'm sitting right now. So it's very nice. They can just go back and forth, and they have very specific scenarios that they do during the sims with our sim faculty. In terms of the clinical preceptorship, they're either assigned to a senior resident or a faculty member. It really just depends. We try to maintain continuity for a certain period of time so they can learn the same techniques versus every day with a different supervisor. And at the conclusion of the 4 weeks, they take something called AKT exam, which is an anesthesia knowledge exam that kind of gives them feedback on what they have learned for the last 4 weeks. Then in July, usually it's additional 3 to 4 weeks of continued boot camp, but it's completely a clinical focus. So no longer the lunch every day, 2 hours a day. They're really now providing a full OR day of clinical service. They may have a little sim maybe once a week here and there. And then individual assessments are done to determine who and when is able to, we call it double covered, meaning that they have an operating room completely by themselves, and the supervising attending may be also covering an additional operating room versus a one-to-one type of scenario. So we're pretty flexible. If a resident really wouldn't be quite up to flying solo, that's okay. No one's meant to feel bad. Everyone's a little bit, different in terms of their learning curve. And that's pretty much how we do it. The residents, because we have other rotations in the CBY year that are anesthesia-based, like acute pain, chronic pain. This upcoming week, they're going to spend a week on PACU, code blues. We sort of kind of know them by the time they start in boot camp, which is nice. Often a lot of the senior residents already kind of been with them on acute pain or chronic pain. So I think the transition is pretty good. We're always looking for advice to make things better. This particular year, we gave them kind of like we called an exit exercise. We didn't want to call it an assessment to create all anxiety, like, oh, they would fail it and not be able to be an anesthesiologist. So we just called it an exercise. And basically, it was a bunch of booby traps that we set up in the operating room. I don't know if you ever done like an escape the room or something like that. So we kind of made it fun, but it all had learning. Like there was a hole in the endotracheal tube balloon, all these little things, hole in the vent, and the other things like they just had to do just to make sure that they're ready to do the basic troubleshooting when they're going to be going solo pretty soon. So that's in a nutshell summary of what we do. I don't know, Dan, if you want to add anything to that. Oh, they do buddy call too on the weekend. So they're not taking full call, but they come in for a half a day on either Saturday or Sunday, buddy up with the call team so they learn how to set up a trauma, learn to see how sometimes things go very quickly in anesthesia compared to the elective cases during the week.
Yeah, I mean, that's a very good question. That was when I applied for residency, that was on the top of my mind. Like you get through intern year and then you do anesthesia. So everybody's got to do this. Intern years can be hard no matter where you go. But and then when you start your CA1 year, it's kind of like another intern year. You're kind of starting from scratch again. You don't know what's going on. It's just a very big learning curve. So again, like a lot of other programs try to sprinkle in some anesthesia electives throughout intern year, as Dr. Schabel mentioned, and then the introductory to anesthesia month, halfway through May into June. That's where you recollect as a class. You come back all together. You're paired up with a senior resident or attending, and then you have lectures in the afternoon. And that's a really, really good way to prep yourself for July 1st. And then everybody progresses at different rates, and faculty is very supportive of this. We have every faculty member is willing to take on residents and put them under their wing for the first few months, and are single covered with them. Same with senior residents. So it's like a very tailored experience early on for every single resident. So if you feel like you're falling behind, you can voice that to your senior residents, your chief residents, to Dr. Schabel, and we can tailor things for you. We can set you up with attendings that you work better with or learn better with. So it's really all about facilitating your growth within those critical like first few months of CA1 year. And it's a very exciting time overall.
It sounds like a really strong foundation for your, new CA1s. It's really comprehensive. And I like the idea of doing a kind of escape room-esque assessment. I know one small, tiny thing being off can really set you back, even if it's just someone clamped the IV and you can't figure out for 10 minutes why it's not running. So there are definitely really important things to think about, the ET tube and everything having a hole. And last but not least, our very own Dr. Smith. I'd like to pass it off to you.
Yeah, so one of the things that I really like about our program is, again, we are a four-year program. The obnoxious noise outside, they're cleaning our windows. So they're out there making quite a bit of noise. But anyway, one of the nice things about our PGY1 program is that we have a total of 14 weeks that the residents spend in the Department of Anesthesia. So that is 2 weeks of POCUS, and that's with anesthesia faculty. They do 2 weeks of patient safety and quality improvement. They also do a total of 4 weeks of, they do 4 weeks of pain. And going forward, I think this probably wasn't true for Raul, but it will be true going forward. It's going to be divided between acute pain and chronic pain. And then they also do OR anesthesia, and they do a total of 6 weeks of that. And that's all scheduled. The 6 weeks of anesthesia training is put deliberately in the second half of the year. It's for some people it's continuous, for some people it's broken up a little bit, but not too much. And so the result of that is actually when our residents start as CA1s on July 1st, they are very ready to hit the ground running. Regardless, during that first month, they're still paired with an attending, and they also have like a backup attending who's sort of their mentor and who they work with like almost exclusively to kind of learn the ropes. But we found that since we've been able to, since we've integrated more anesthesia into the PGY1 year, we've been able to give them more autonomy a little bit earlier. They're just ready. They're maturing faster during that first month. They also do get, like most of the other programs mentioned, we also have a didactic series that's an hour of lecture a day. That's for the CA1s. And I don't know if, but I mean, anyway, let me give you an example of like the result of that. So this afternoon, one of the summer is always very busy at our hospital because that's when everybody goes outside and like gets into motorcycle accidents. So they were very busy in the OR, and the attending who's supposed to be getting lecture this afternoon to the CA1s was working in an OR with the CA1s. So obviously that wasn't, they needed to be relieved so that they could go to lecture. So the person who was running the floor said, "Oh, Sarah, would you mind just going in and helping out and getting them out?" So sure, no problem. So I go in and I get report from the CA1, and I was like, I feel like I'm getting report from a much more senior resident. Like this doesn't feel like somebody who's only been at this for 2 months. And just as like another example, I was working with a CA1 the other day ago, and we had to put in an arterial line. And not like that's the most complicated procedure in the world. I mean, A-lines can be very tricky, but I still, when we were about to do it, I kind of asked him, I was like, how many of these have you done? And he was like, oh, I think it's 4, and this is like halfway through August. So they really are able to, hit the ground running. We immerse them very early, and it definitely pays off because they mature very quickly. And I'll let Raul say anything that he can add.
Yeah, so I think it's really great to start off with anesthesia in your intern year. It really, by July 1st, like I did feel much more comfortable in the operating room setting. And even during that time, the first few weeks, you're paired with an attending, so you kind of learn the routine or how that attending does things before you mix it up afterwards. Another couple things that we also did that I thought was helpful was we had like didactic series even during intern year where we would go through Miller. And so you're, in addition to learning like the hands-on stuff in the operating room, you're also learning some of the like technical things from the book, which kind of is helpful. And when you see that stuff in the OR, you can, put it together and you remember it better. So that was really nice. And also in my experience during the 6 weeks during intern year, you're working with a senior resident. So it really gives you the opportunity to, ask, it really takes off a lot of the pressure of like, oh, this person's going to evaluate me, where you can really ask anything, there's no expectations for you. So, you're always comfortable, learning and growing at your own pace. So I thought that was really nice.
Oh, fantastic. And Dr. Smith, you're definitely doing something right, because I've mistaken multiple CA1s for senior residents. In the past month, I've been rotating with you guys. So I agree. They are so fantastic. You would never know that it's the second month of their CA1.
Okay, so thank you all for answering the previous question. We'll move on to the next one. This one's geared towards the program director specifically. And the question is, how do you think this application cycle will differ from previous years, if at all? And I'll just choose at random and we'll start with Dr. Schabel.
I think it'll be similar to last year because the number of signals are the same. If people aren't aware that applicants will have 5 gold and 10 silver signals to allow there to be a communication between the student and a program director where their interests may be. The whole goal of this is to decrease the over applying. So maybe we will see a few less applications this year. I don't know if that's truly going to happen, but the data that we learned from last year is that if you did not signal a program, either gold or silver, it really decreased the chance that you would be given an interview. So for the most part in our program, and I think most programs are using the signaling to determine interview invites, maybe not so much the final ranking order. So my, I guess, advice to those who are 4th years, be very mindful with how they use their signals. I wouldn't use them all up on REACH programs, right? Because perhaps that REACH program may have 250 signals. So be really honest with yourself where you may feel you're competitive. And, I guess similar like with medical school, apply to a variety of different places and use your signals for or maybe REACH, more target, and maybe somewhere you feel like, oh, I think I'm pretty sure I could probably, get a spot in that program. But time will tell. What is it, September 23rd or 4th or wherever the application's open. We'll kind of learn more as we go through the cycle.
Yeah, thank you so much for sharing that. I think from a student perspective, sometimes the signals can kind of make or produce mixed feelings. So just to have you kind of offer your perspective on that, I think is really helpful for everybody listening in. So I appreciate that. I think we all do. The next one on my screen is Dr. Aronsohn.
In many respects, I agree with Dr. Schabel, and for us, it's going to change. The application season is going to change a little bit because we have, that many more people that we are, listing in the match for both, the CA1 class and the PGY1 class. And I agree with her assessment of how medical students use their signals, that they need to be used, wisely. I also think, though, that, and I don't know whether anybody is thinking about this, that, the original purpose of the signal was only to let a program know that they were interested in an interview, right? And not necessarily you could change your mind about a program when you went for an interview, right? You might go and interview there and go, why did I waste my gold or my silver here? I don't really like them. And not necessarily the program shouldn't be using them to make a rank list. But we are seeing increasingly more programs only interviewing people who sent them signals. So clearly then those signals are, as a result being used, you have no choice. You're only ranking people who sent you signals. So I think that using them wisely is very smart. I will say that there still are programs out there, though, for those students that are out there that will interview people who didn't send them signals if they see something else in their application, or they get any kind of indication from an applicant that they are interested in the program even after they sent their signals. So I don't want students to think it's a lost cause that, you know, if I don't send a program a signal, I'll never get an interview. And I also don't want the students to think that because you send a signal that you're automatically getting an interview. I think there's a balance in there, you know, if you're applying for a lot of REACH programs, or for some other reason, there's something in your application that does not meet the criteria of that particular program, whether you sent them gold or silver, you may not get an interview. And if you're a wonderful applicant and you feel like, oh, gee, you know, I should have considered sending this program a signal. I didn't necessarily like all the programs I sent signals. There's still chances to get interviewed. So don't think that everything is in that signal pot, is my message.
Yeah, thank you for further expanding on that. We'll jump to Dr. Smith for the next one.
Yeah, so I agree with everything that Dr. Aronsohn and Dr. Schabel just said regarding the signals, and I imagine this year is going to be somewhat similar to the year before. Maybe there will be a dip in applications just because people won't be sending out quite as many, but you know, time will tell. I do think it's going to be very competitive again. You know, as I'm sure you're all probably aware, there was, I think, only one unmatched spot in the whole country last year, which is kind of incredible. Yeah, and you know, be very careful about how you use your signals. Yeah, there are some programs where it's kind of, if you do not silver or gold signal them, you're not getting an interview. And you know, I am not one of those programs, but you know, the numbers speak for themselves. It's like your chances of matching into a program if you signal them is much higher than if you do not. And I believe for my residency class that we just matched, if I'm not mistaken, of the 13, we only had 3 people who did not signal us, but they, but you know, I mean, I guess that's sort of the other side of the coin, is like they didn't signal us. We saw something in their application that we liked. I will say they did all geographically signal us, so I was, you know, it's like there was some indication that they wanted to kind of stay in the area or something along those lines. And we matched with them, and you know, but so yes, you know, please talk to your mentors about constructing that list, you know, very carefully, who you're going to send your signals to. And other big changes. Well, I mean, one phenomenon that I don't know if anybody else has seen this, but one change that I've seen is with the signals, it seems like it actually kind of decreased our geographical diversity a little bit. You know, we went from getting, every year we would have residents, oh, we had you know, somebody who came from Puerto Rico, and we had somebody who came from Nebraska and North Dakota, and, you know, sort of different parts of the country. And it seems like things shrunk a little bit. You know, I can't explain exactly why that happened. We certainly weren't seeking out only people from, like, you know, New York and New Jersey, but somehow it's sort of, when we got our match results, I was like, oh, everybody's kind of like a local, you know, which is fine. But that was just a change that I saw, and I don't know if other programs are observing the same thing.
Yeah, thank you for adding to the talk about the signals. I think it's also really good to hear too that programs aren't only giving interviews to people that signal as well. So if there's some that people are still interested in and they don't necessarily use a signal on, it's still a very good or very encouraging to hear that for those people. Last but not least, we'll go to Dr. Frenk.
I agree with the other program directors about the signal, and I'm not going to add anything about it. What I wanted to kind of like talk about a little bit is geographical preference, because some people signal not necessarily by gold or silver, but by geographically. As a program director, you know, we looked at a variety of different factors in the applicants, and one of them would be, if this person is willing to come here, why are they willing to come here? Is it because of the program? Is it because of the location? Is it because of both? Or so in addition, there is another category of students that nobody mentioned, and those are the students who rotated with you and they didn't signal you for one reason or another, maybe because they want to hedge their bets, maybe because they feel that due to the personal nature of the relationship they developed with your program while rotating with you, they don't really need signal you because you know the program knows that they're interested. I would encourage these students to still signal because you know, to indicate your interest in the program.
Thank you. Thank you all for contributing to the talk about signaling. As I alluded to earlier, is I think like students have a lot of mixed feelings and don't it's like kind of hard to keep track of and know how to go about it. So it's really nice and important to hear perspectives from all of you. I'm going to let Caitlin take away the next question.
Thank you for explaining so much about this application process and how it may or may not be different or similar to last year. I have another question about your specific programs. If you wouldn't mind sharing, what 5-year goals do you have for your programs? I'll start with Dr. Smith.
So, you know, one of my 5, the first thing that comes to my mind is that I think, and one of the things I'm really excited about is that we're really growing we're growing academically. You know, we've always provided really good clinical training, and I feel very confident saying that because, you know, I see the residents that graduate with us. I, you know, see the way that they practice before they go out into the world. And then we also send out surveys to their employers, whether that's a fellowship director or, you know, an actual, like an employer or private practice, saying like, so how are they doing? You know, and we get like universally, it's like, oh, this person's great. You know, we have 2 of our graduates from a couple of years back are working at one of our affiliate hospitals, and they've really become like a core part of the team and are sort of like leaders at that affiliate sites, so it's really exciting. So I've known that we always provide like a really good clinical experience. But we were a little light on the academics. We're not an ivory tower. And, you know, I don't think we're going to become like an ivory tower overnight in terms of our, you know, like research or, you know, publication chops. But, you know, we are growing in that direction, which I think is really exciting. Our director of research, who's Dr. Iram Salek, who she is a pediatric anesthesiologist, and just over the years really developed, she just became very enthusiastic about publishing, and she started small. She started with like case reports and doing reviews and educational type writing, and she just kept wanting more and more and more. And I'm convinced that she might be hypomanic or something. I don't think she sleeps, but she then she went and did a course with Harvard. It's sort of like an accelerated training program for learning how to do research. And now all of a sudden she has like 25 IRBs. So that's what I'm really excited about. And I think that that's going to be the big change that we see in the next 5 years, is that, you know, maybe we won't be an ivory tower, but we're going to be maybe like brass, or, you know, one of like the lesser metals, something like that. You know, so yeah, let's see, that's one big change. I'll let one of the other program directors take it from there, but that would be my number 1.
Thank you so much. I'd like to pass it next to Dr. Aronsohn.
Well, with our new academic chair, I mean, the sky's the limit. So I would say that, you know, not dissimilar to what's already been mentioned, we have, you know, such a volume of clinical training here that, you know, the next step in that area is, you know, after we double the size of the program, is to add fellowships to the program and really try to get more innovative with our curriculum. I think that there are many limits, you know, to having a very, very small program. And you want to make a statement in your department when, you know, and part of having a larger program is making an academic statement, because there are requirements to, you know, having a residency program, and there are not only scholarly activity requirements, but research requirements for faculty. So expanding the program, expanding your fellowships actually, you know, puts an expectation in your department that things need to grow in that direction. So we have our own dedicated research department already, but with a new academic chair, we are expecting that this part of our program actually will grow, over the next few years. We also expect to add a lot of other, first of all, grow our global, health rotation now, maybe add a rural health rotation to the curriculum. There's so much that you can do with a curriculum when you have, 20 residents in a year. We're only going to have 12, but 12 is a start. And, you keep building that. And there are just so many innovative things that you can do with the curriculum. I can't even name them all. I wouldn't want to waste everybody's time, but my mind's always working. And as we add those, the opportunities that residents are going to have when they come is going to just expand and grow. So certainly the research and scholarly activity aspect of our department is going to grow, and our elective rotations and the choices that residents are going to have is going to grow over the next 5 years.
Sounds like things are going in a really exciting direction. Last week, Dr. Abramowitz said a program that doesn't change is a program that is dead. It sounds like your program is very much alive and well. I'd like to now pass it off to Dr. Schabel.
So one of our goals for our program is to have all of our residents become ASA certified in POCUS, a point of care ultrasound. I personally, and even our faculty, do believe that POCUS is our future. It's non-invasive. It helps you all the time in anesthesia. Traditionally, everyone feels it's more of emergency room, bedside, NICU. It doesn't really have a role in the operating room or in perioperative care. But more recently, we've just been seeing the many wonderful implications of it. For example, probably students know a lot of people are on these GLP-1 agonists now that can affect gastric emptying, and then back and forth, whether the rules, when do they stop it, when do they not? There's a lot of controversy. If you know gastric ultrasound, it doesn't matter. You take the probe, you put it on the stomach, bingo, you kind of know whether you should proceed, whether you should not proceed. The little kid, we think that they swallowed the Skittles. We don't know if they swallow the Skittles, the NPO, what do they sneak in there? You just put a little probe there. So that's one example. I do a lot of OB, and sometimes we have a preeclamptic and then they're not making urine, and well, are they dry or are they down the early kidney failure? You used to have to put a CVP. It's a wake patient. Nobody likes to do that, other things. We take our ultrasound out, boop, we look at the IVC. If the walls are kissing, boom, fluid, we just kind of move from there. So we really believe this is the wave of the future. The ASA certificate program is something that was developed by the ASA. As a program, we've been doing POCUS workshops and POCUS teaching throughout our program for the last several years, and even give the residents a butterfly ultrasound on one of their rotations to practice. But we really felt that having them complete the course and getting their certificate really standardizes their experience across the board. Sometimes residents take vacation or they're on nights, so maybe they would miss some part of the day didactic. And also we thought maybe just will help them for their next job and getting credentialed wherever they may go. If you come in with a piece of paper saying that you've done 110 and you've completed an exam, it may just really help their new employers know their level of proficiency in POCUS versus just saying, they completed our home program. So I don't know, we're giving it a try. We just started it. It is expensive. So it is something that our department did have to pay, which is always, back and forth, when you're looking for funds, but we did get the funding from the department, and that's something that we're starting now, and it will be a 2-year program for our residents, so that we hope that they will complete it within a 2-year period of time. Down the road, we also may, I'm not really sure, maybe expand our program by just a little bit. We're currently at 12. We may go up a little bit more, but I'm not completely sure. I'm thinking about it. But focus on POCUS is a big wave of our program right now.
That's really fantastic. Some of us, Kerrigan and I, we were in a lecture today, and the speaker was talking about how POCUS is the future, and that it would be something to ask residency programs on the interview trail. So I'm really excited that you shared that with us, and that you're going to be trialing something new like that. And last but not least, Dr. Frenk.
I'm last but not least a lot, I noticed, but that's fine. Okay. Well, as opposed to other established program, our job, I feel within the next 5 years is to become established and consistent. And in order for us to do this, we have to stay as a newer program where we have to be flexible to our residents' feedback as well to their educational needs and make sure that they are all satisfied. So one of the things that we are implementing, even though we just literally started the program, one of the things we felt that would be really cool is for our residents to shadow otolaryngologists in their office. That was actually Moham's idea, by the way. And so we had one of our private otolaryngologists agreed for our residents to come on their airway rotation to their office and to do nasal endoscopies and learn how to operate the scope, and that will provide it with very valuable skill for fiber optic intubations and things of that sort. And I think that this is super cool. And we're always looking for some out of the box ideas and something new and innovative, just to keep us all on our toes. And that's our 5-year goal.
Awesome. Thank you so much all for answering and kind of sharing the vision for your programs, and letting us all know, the ones at least applying this year and maybe next year, kind of what we may be able to look forward to if we were able to go to your programs. The next question is again for the program directors regarding personal statements. It was a really commonly asked one. And the question is, what is something that makes personal statements stand out? And then the second component of the question is, how do you feel about applicants tailoring their personal statements to explain why they may be interested in your specific program? And to start, we'll start with Dr. Frenk. Not last this time.
Excellent. How do I feel about the various personal statements? Listen, there are a lot of personal statements that are not really personal. They're personal to the extent, but the themes are very common. And we're always looking for something really personal and special reading somebody's statement. And that makes a difference. And some people tailor their stories to their life experiences. Some people tailor it to their hobbies. I had a personal statement from the applicant. That was an entire personal statement about heavy metal drums. And it was fantastic. It was different, loved it. And as far as tailoring it and explaining why they're applying to your program, I think that that's great, especially if, from the first glance at the application, you can't really figure out, okay, why is this person applying to our program? And then if the personal statement explains this, then that clicks and you're like, oh yeah, that makes total sense. And that will that can make a difference in offering somebody an interview or not. So.
Thank you. That was very insightful. We'll just keep moving. Dr. Smith, would you like to go next?
Sure. So regarding personal statements, I always pity the people having to write them, because it's such a hard thing to write, it's too open-ended. But number one, make sure it's well written. If you are not a good writer and you know that you are not a good writer, please get a friend or somebody else who is a good writer to read it. Because the impression that I have definitely read personal statements where there are misspellings, there are grammatical errors, and I'm thinking, and I can't help but be influenced by that. The thinking is, somebody who can't focus on the personal statement can't focus on setting up their OR correctly. Do not use AI. I will know. And I have picked up on a few that were written by a robot. And that just tells me that you're probably not very industrious. And then I would also just agree with everything that Vlad just said, keep it personal, keep it genuine, and try not to rehash the same things that we've heard a dozen times before. Yes, I do want to hear, why are you going into, anesthesia? I guess I'm a little different. I don't like the statements where somebody's talking about something else the entire time, where they're trying to say, oh, anesthesia is just like this random hobby that I have. I've kind of read that statement before, but so I do want to know why you're going into this field, but just like keep it personal, keep it genuine. Yeah, and avoid some of the cliches, like, I've read it's like, oh, I really love, physiology and pharmacology. I'm like, well, don't we all? But then again, yeah, like I said, I know I'm sorry, I know they're hard to write, but I really do read them. We're not one of those programs that, I do think there are programs out there that kind of gloss over them or they don't, I do read them. So, just like be yourself, treat it like you would, a paper in your AP high school English class, and, do your due diligence, and just be yourself.
Thank you so much for adding to that. Next, we'll hear maybe from Dr. Schabel.
So I would agree with the advice given by Dr. Smith and Dr. Frenk in terms of making it personal. This particular writing should not apply to anybody else. There's no other medical student who this would be appropriate for. So be mindful of spending the whole time talking about the physiology and the pharmacology and intimate relationship with patients. You're telling an anesthesiologist what the field is about. I know that because that's what I practice. I really want to hear about you and maybe specific things in your life that you feel would make you a good anesthesiologist or led you to anesthesia. No typos. I agree with having other people just look at it and giving feedback, being positive. The program director does not know you. So if you start the personal statement just with a lot of negative type of statements, or you didn't like anything else, you didn't like peds, you didn't like surgery, and then all of a sudden I found something that I liked. I mean, to be honest, we take care of kids, right? We're in the OR a lot with surgeons. We go to OB. So if you're crafting this whole personal statement of the whole third year, how it was like not for you, not you, and then all of a sudden you found something that could backfire potentially on you. In terms of crafting, like leaving a little bit at the end to talk about the program, if you like something about it, I think that's perfectly fine. Just be very organized. Do your due diligence. Don't write something in that last paragraph that has really nothing to do with that program, or certainly don't name another program in that statement. And I've seen both of that, where just people in a rush, just be attentive to details. If you're going to customize it, just make sure you're sending that customized personal statement to the program that it is meant to go to, not to another program.
Thank you so much. Lastly, we'll call on Dr. Aronsohn.
Well, I'll keep it brief because everybody, look, every program director is different, and probably everybody that reads the personal statement, even on any, resident selection committee, is going to have their different, takes on what's being written. I will say I agree wholeheartedly. It should be well written. If it's not well written, you already lost the reader. Your graduate students, you are, it should not sound like a ninth grader wrote it. First and foremost, you will lose anybody who's reading it right then and there. I'm going to say don't make it too long either, right? 1 page is quite enough to, put what you want in that personal statement. Get the information that you want to convey to the reader is in the personal statement. It does not need to go on for 1.5 pages or 2 pages. Most people are not going to read that long. And make sure that first paragraph has content in it that someone's going to want to read it further than the first paragraph. So you're going to catch the reader in the first paragraph. If that first paragraph doesn't have anything in it, regardless what you put in it is up to you. But if it's not interesting enough to hold the attention of who's ever reading it, they're not going to go on to the second or third paragraph after that. So well-written, information in that first paragraph that's going to want to make people read more, and don't go on too long because people are not going to read 2 pages of a personal statement. You want to put something in at the end, to that particular program because that program has attributes that you like, and you want to let that program director or that selection committee know about it. That's fine. That's great. But make sure that you don't get too crazy with it because, the first thing a program director is going to ask when they read this, a whole paragraph about how much you want to be at that program and you didn't even signal them is a little bit of a, going to leave a little bit of a bad taste in their mouth. So again, just like you be selective about who you are sending those messages to, and definitely don't use half your page just as a personal message to the program. And if you do all those things, I think it's fine. We do want to know who you are. So use that time and space to write in a way that we do know who you are.
Thank you so much for all your perspectives. It was said earlier, it is by Dr. Smith, it is just a very broad and kind of general thing that you have to write and approach. But to hear you guys all bounce off each other's answers and really is helping us kind of, pick out the important parts. So there are things that we know that we absolutely have to do when we write the statement. I think for the next question, I'll pass it on to Caitlin again.
Thank you, Kerrigan, and thanks everyone. I'll just be casually writing and rewriting my personal statement 100 times after hearing all of your responses. So thank you. It was very valuable. For the closing question, as we get closer to the hour-and-a-half mark, I just want to invite you to share your opinions on what you think the field of anesthesia might look like in 10 years' time, how you think it might be different, what aspects do you think will be emphasized? We can start with Dr. Frenk.
I feel that the field of pain management is going to change because there are new, not only technologies, but there are just new approaches that are being developed right now. Cryogenic therapy and so on and so forth. So I'm hoping that within the next 10 years, those treatments are going to be tailored, and a lot of people will have literally pain-free anesthesia. Also, medicine is becoming more and more personal, based on genetic and phenotypic modification. There's a lot of research happening in multiple areas, and all of our anesthesiologists know that for some reason red-haired patients require more anesthesia, and there are plenty of research says it's not so. Sarah, what do you think? Is it so or no?
Yeah, I think it is, and there's actually a sort of chemical basis for it, because the gene that's mutated, it's a recessive trait, and the gene that's mutated, it does more than just give you pigment. It also works in the brain. So there's probably some truth to it.
So, and I
They
feel
also have a higher pain threshold.
that's true too. So I feel that as the field evolves, we're going to have more and more ability to titrate individualized treatments to the patients, which will improve their outcomes. That's number 2. And number 3, when we think of anesthesia, we think more kind of like the intraoperative black box. And I hope that within 10 years, the field of perioperative medicine, all encompassing, is going to be owned and run by anesthesiologists as perioperative physicians who will own the entire process from the moment the patient is scheduled for surgery to the time they're discharged from the postoperative arena, because we are best suited, and we're all aware of all the intricacies involved in the process and perioperative process better than any other discipline, in my opinion. So I'm just hoping that that's what's going to happen in the next 10 years. Thank you.
That sounds like a bright future, especially when you say pain-free. I know many people all over the world would love for that to be their reality. So hopefully we can do it for everybody. Next up, I'll jump to Dr. Schabel.
So for in the next 10 years, I predict that the current national shortage of anesthesiologists will certainly improve, because there's a lot of interest by you all medical students going into the field, and there's a lot of new programs popping up to help meet the shortage. Hoping so. On the flip side, our population is getting older, having more and more procedures, so the need may continue, and hopefully the supply will get close to meeting the demand. I think more and more procedures will continue shifting to office space, less invasive technology using to help with the procedure. So a lot of new learning and how to provide anesthesia for those cases. And then the whole ERAS protocols, we're big on ERAS here, but that certainly applies to try and get most procedures, getting the patients home as soon as possible. And if it's a new patient or a new type of procedure, we have to kind of figure that out. New medications too, right? Ozempic, GL1P agonist, we just spoke about that. So I think the next 10 years as new medications come out, we have to adjust as anesthesiologists. Probably the big one, I think right now we're in a national shortage of anesthesiologists. Staffing is tough in a lot of places. In 10 years from now, I think it'll be much better, much improved.
Thank you. Next I'll jump to Dr. Aronsohn.
Hard for me to follow the players that have already gone. I think though that AI, and don't ask me how, but I think AI is going to be a big part of anesthesia, as it will be part of every specialty. It's, you see now how it's starting to be used, and there's plenty of papers being published on its use. And technology in general is going to change, I think, this specialty in ways that we can't even really necessarily imagine, 10 or 20 years down the road. I worry, and I think a lot about, and Dr. Schabel mentioned, enhanced recovery protocols and the protocolization really of how we treat patients, which is shown to be safer, but also, kind of takes the artistry out of what we do away from us in many, many ways. I think a lot about keeping this specialty as a physician-led specialty, which this really speaks to my heart. And I know hopefully there's a lot of young medical students listening now who are going to be the future of this specialty when I'm, long gone, after this. But keeping this specialty in the hands of physicians is, to me, extremely important, so that, we need to innovate and grow and actually practice, make sure we're the leaders of all these areas of growth, right, down the line. The more protocolized it becomes, the less the less available, the more available it becomes to others to be able to do, and and the necessity of having a physician is going to be less. So I am a real big believer in, we're going to be catching up to the deficit we have in anesthesiologists probably in 5 or 10 years. I don't know how long it's going to take. All of us are going to have to be at the cutting edge of the new technology and new drugs that come into this field, and we're responsible for teaching, our new residents and our new faculty on how to use it. Everybody's going to have to stay on the cutting edge of this in order to not only keep this a physician-led faculty, but grow outside of the black box that is now the operating room, where we spend most of our time. And when Dr. Frenk said, when the patient comes into the preoperative area to the time, they go to the PACU, I think I look at expanding it way broader than that. It should be from the time the patient walks into the hospital to the time that they leave the hospital, that anybody having a procedure or surgery is owned by anesthesiology, right? Because we are the ones that should be in the best position to use all the technology at hand to make sure that outcomes are absolutely optimized for these patients.
I love that idea, expanding the reach of the anesthesiologist in the hospital from when the patient comes in to when the patient leaves the hospital. And to close us off with your wisdom, Dr. Smith.
Yeah, I don't know about wisdom, but yeah, I agree with everything that everyone just said. I mean, but I think we also have to be ready for the unexpected. If you'd asked us this question, I'm trying to think back, well, what if you had asked me this question 10 years ago? Would I have predicted, the COVID pandemic? No, and there are other things, expect the unexpected. I don't know everything that's going to happen, but I do agree that what I think we need to do as a specialty is, to take ownership of this entire arc of the patient and what speaks to that is, one of my chief residents from last year is now doing a fellowship at Duke, and I'm going to mess up the name of the fellowship because it's relatively new, but it's a perioperative medicine, so it's about preoperative optimization and running a preoperative clinic and those sorts of things. And then it kind of reminds me of when you're asking about what are the changes that we anticipate seeing in our program in 5 years, and I was like, oh, I forgot about our new critical care tower. And so we're building a new 128 bed critical care tower, and as a result, we're ramping up the number of anesthesiologists with critical care training that we're employing in our department. I think a lot of, particularly like, bigger, busier places are kind of going in that direction, taking more ownership of ICUs. And then I think it's going to take us a while to get over the shortage of anesthesiologists. One kind of I guess hot take on the situation currently with fellowships, because a lot of people, the job market's on fire. And, all of you have more, and I say this with all seriousness, you have more than twice as much debt as what I had when I graduated. And, I completely get it. Like, I completely get people just wanting to go out and get a job and make some money. That's totally fine. But because the number of people going into fellowships has fallen off, I think in about 10 years or so, there's going to be this big need for people with subspecialty training. So if you are somebody who is sort of like in love with pediatrics, or you're in love with cardiac, and like that's what you want to do, but everybody, like, people are poo-pooing going into fellowships, like, do not despair. If you really love it, please, please, please do your fellowship. That's the perfect reason to do a fellowship. And I actually think that we're going to need those people a little bit down the line.
Thank you so much for sharing all of your perspectives and kind of how you see the future of the field. It's super insightful for all of us going into it. With that, I believe that was our final question, taking us to right about 7:30. So I just want to close here. And again, thank you everybody for joining us tonight. I especially would like to give another round of applause to all the program directors that have given us their time tonight and their wisdom, Dr. Smith, Dr. Schabel, Dr. Frenk, and Dr. Aronsohn, as well as the residents that took time out of their days as well to come and speak and give their perspectives, Raul, Jasmine, Dan, and Maham. I hope our viewers are sharing the round of applause, and I hope they also learned as much about each of these unique programs in the field itself as I did. So as a reminder, the third event of our series will be happening on September 10th at 6:30 p.m. The format's going to be the same, and we hope to see you all there. So thank you so much, everybody.